First of all, it's an honor to stand here in front of you all and present. Second thing, I would like to really congratulate the organizing committee and the scientific committee for this important meeting. I've been really, till now I have really enjoyed the sessions. What I'm going to talk about today is a little bit a wider topic than just how much does an LVAD cost. So what I'm going to do, if you all agree, I'll go through the economic burden of heart failure and then take it down and scale it to economic burden of heart failure in Saudi Arabia, and then take it down further on how much of a burden would we need, or how much of resources would we need to establish a VAD program. For heart failure, I just want to go through three concepts. The first concept is that heart failure is not a disease entity. It's a consequence of other diseases. And to really tackle heart failure, you have to go in any specific society or community, you have to go and look for etiologies. The other thing is that heart failure or any cardiac disease, it starts with an acute event. This acute event, we have to save that patient with the acute event, and most probably we don't cure these patients. We transform them into a chronic disease that we have to manage for a long term. That long-term management needs real strategy and a multi-layered approach. So these are the three concepts that we should look at when we're doing that. Sorry about that. So here, this is a beautiful chart, and the most beautiful thing about it is you know, the fatalities or the deaths per 100,000 population from cardiac disease is decreasing year after year. And if you can see, the tipping point of that decrease is where, you know, cabbage is. Cabbage is here, and you can see after Favalaro introduced or described cabbage, everything started. So you just introduce surgeons to the equation and everything gets better. But you know, that's just a joke. But anyway, we are winning. For cardiac diseases, we are on a winning streak. This is another, you know, the invention of what we call now of a CCU. Before we had just hospitals, and the MI patients would be admitted to the general ward, and we had a mortality of 30% of acute coronary syndrome patients. After the invention of a CCU, a dedicated CCU, that decreased to 15%. And now with the primary PCIs and early reperfusion, revascularization, that mortality is less than 3%. In fact, it's the international benchmark is 1-point-something percent. In spite of that, ischemic heart disease is still topping the list for the most common cause of death worldwide. Now, this is an interesting slide where we are really dealing with the tip of the iceberg. The part that we don't see is the 50-60 million patients in the U.S. With stage A, which are patients that are at risk for heart disease. Then you have another 8 to 10 million stage B for patients that had an event before and are at risk of having heart failure in the future. Those we don't see. What we see now is stage C and stage D, which comprises around 5 to 6 million heart failure cases in the United States. We think that in Saudi Arabia we don't have accurate data, but we think in Saudi Arabia we have around 500,000 heart failure patients. In the States, there is around 250,000 stage D patients. We think that in Saudi Arabia we have around 20,000 patients in stage D. The heart failure incidence is increasing despite better cardiovascular care. That is because of different reasons. I think the most important reason is that we are saving the acute cases. We are managing the acute coronary syndromes in a better way, and we are managing our health in a better way that we have an aging population. This is the burden of heart failure. The projected burden is much lower than the actual burden. The actual burden is increasing exponentially year by year for the reasons that we mentioned before. This is just a more elaboration on why is the prevalence increasing, although that the incidence of cardiovascular disease in general is decreasing. The aging population, the better management of acute coronary syndrome, the improved heart failure management and improved heart failure survival, prevention and early revascularization, and of course advances in technology. Most of the studies are done in the United States and Europe, but if you go to the lower income countries and continents like the African continent, you can see that most of the patients there that have heart failure is due to still valvular heart disease. Here in Saudi Arabia, valvular heart disease is an important cause of chronic heart failure. Now we go to economics. The health economics is different from any other economics. In general, if you want to buy a car, you go to the dealership and you could know about the car more than the dealer himself because you did your research. Now in healthcare, first of all, the buyer does not buy directly from the seller. The patient should go through the insurance company, and the insurance company or the government would pay for that, would approve and then pay the provider for the service. So that takes something what economists call the invisible hand of the market away from the equation. So in this case, the customer does not know better. The customer does not. There's a big difference in knowledge between the customer and the service provider. And there is another entity or a third entity that controls the resources, that makes major decisions and policy making for both the payer and for the patient. Key concepts describing a healthcare economy and reflection on heart failure. There is something called externalities, the prevalence of externalities. And in heart failure, externalities is a big issue. Now, if we do everything right in the hospital for heart failure and the patients decide that taking medications or adhering to their medications is not important, this is a very important externality that could affect our outcome negatively. So there is a lot of factors that affect negatively or positively. The externality could be a positive externality or a negative externality, but that's an important factor. And there is also the difficulty in monitoring quality, process outcomes, and effectiveness in all our procedures. There is also a big challenge in assuring equity between different socioeconomic classes, between different patients and different areas in the country. And there is always the efficiency factor. How could we provide the best care possible with the lowest cost possible as well? So the rules governing the healthcare market, as we said, governance or government or private insurance are the people who pay the bill. There is always the moral hazard, which we are affected by it big time in Saudi Arabia when the patients have open access to government facilities. They overuse and sometimes abuse the services. When rationing becomes too much rationing, and that affects patients. And when we are, like when we're talking about LVADs, new medications, technologies, and procedures, when is it too expensive and too experimental? And that's always an issue with diseases like heart failure that we don't have complete solutions for yet. So we'll just go to why should we identify the economic consequences of heart failure for micro and macroeconomic reasons. For microeconomic, at the microeconomic level, we should really make sure that any kind of treatments we provide, that we think about preventing health shocks and health-related impoverishments for patients. I just heard stories in the States that patients who had VADs and then went into complications from that, the VAD, that they have, some of them went into bankruptcy, and some of them went into really important financial hardships because of that VAD. So that's the one thing. The other thing is that on the macroeconomic level, poor health results in poor income, results in poor return on capital and lower domestic and foreign investments, and it just that part of the economy just crumbles down. Now we go to the more interesting part of the presentation, which is the numbers. The global economic of burden of heart failure. This is a study that the meta-analysis went through 13 studies of direct cost. They found 13 studies counting direct costs of heart failure. Only one study addressed the indirect cost. The World Bank data was used in this study, where GDP health expenditure for 213 countries was examined. 92.4% of all global countries and 98.7% of the world's population were included in the study. And like in the States, for example, in 2012, their published estimate of heart failure costs was $30 billion, $30.7 billion. The World Bank estimated their GDP in 2012, the total GDP was $15.7 trillion. The World Bank percentage of GDP that was spent on healthcare was 17.9. So the estimated total health expenditure was $2.8 trillion. If we calculate the percentage-wise, then the heart failure took about 1.1% of the total health expenditure of the United States. The mean direct heart failure cost burden globally, the States it was 1.1, but the mean globally it was 1.32% of the total health expenditure. The World Bank Development Index categorized countries into high income and medium and low income countries. The mean direct cost for high income countries was 1.42%, and the mean direct cost for the medium and low income countries was 0.11% only. And the indirect heart failure cost burden was calculated at around 0.06% of the GDP globally. And now here we have to stop it because, you know, the better though, the bigger the direct, what we spend directly on heart failure, the less the indirect cost. And that's what's happening between the high and the medium and low income countries. The total global heart failure cost in 2012 was estimated at $108 billion globally, and the direct was about 65 billion, which is 60% of the cost internationally, and the indirect was 43 billion, which is 40% of the cost per year. The global per capita spending on heart failure worldwide, if you calculate all the per capita spending, was $28 or $24 per person. Saudi Arabia was part of the high income countries, of course. This is old statistics in 2012. I'll just go to the what we are spending now. Yes.
Mecca.
Okay. I'll just come back to that. I'll just go through the economic burden of heart failure in Saudi Arabia. Just to continue that, our GDP in 2017 was 683 or $684 billion. The health expenditure percentage was 4.7% of the total GDP, which was $32 billion. The direct heart failure cost, this is just an extrapolated from the 1.32%, which is the average global. From that, we can calculate the total health expenditure of 400, and the direct heart failure cost, according to the total health expenditure, 1.32% of the total health expenditure, which is $424 million a year. And the indirect cost we calculated as 0.06% of the total GDP, which was the global benchmark. It's calculated to $410 billion million dollars per year. The total is $834 million, which is 3.13 billion Saudi riyals. Now, if we dig deeper into LVADs, there was a good study done on 220 patients of Medicaid patients in the U.S. Studying the cost effectiveness of left ventricular assist devices in ambulatory patients with advanced heart failure. And in this study, the use of LVADs for inotropic dependent patients has been proved to improve survival compared to optimized medical therapy. But non-inotrope dependent advanced heart failure patients is less clear, with a huge number of patients, almost 4% of the total heart failure population are advanced heart failure, ambulatory advanced heart failure patients. This is a comparison of the model survival curves from different registries, from both the Intermax and Medamax registries. And here it's quite clear that the survival of the LVAD patients is a little bit better than the low-risk patients, the ambulatory low-risk patients, which is definitely better than the ambulatory high-risk patients according to survival. And here, this is what they found. They found that the LVAD patients had double the number of admissions or readmissions to the hospital from the low-risk or the high-risk patients. It had more than twofold increase more in strokes than the high-risk and low-risk patients. Pump replacement was needed in 0.18% of cases. And the cost was double the cost of the high-risk and low-risk patients at at $726 million a year, compared to 300 and 250 for the low-risk and high-risk patients. And on this cost was the cost of the increase in the actual life years and the quality-adjusted life years of around, like if you compare between the high-risk and the LVAD population, which was around 2.6 years. The ICER per quali, which is the metric that we're going to talk about in the coming slides, found that the ICER per quali for the low-risk, for the LVADs for low-risk patients was quite high, it's 209,400, and for the high-risk population was $171,000 per year, ICER per quali per year. So in this paper, as we said, 220 patients with LVADs implanted. Mean cost of the LVAD implantation was $175,000 per year. Mean cost of the pump replacement was $90,000. Patients had a combined 589 admission days in the year following LVAD implantation, and most readmissions were for cardiovascular causes and were longer and costlier in the LVAD group. Projected economic and health outcomes, for the low-risk patients. As we said, it costs $726,200 per year over 6 years for every patient. For the LVAD, $268,700 cost of readmission for per year for every LVAD patient. $175,400 device implantations. Was the cost of the device implantation, and if we compare it to heart transplant, which costs $62,000 only, so that's half the cost of the LVAD. Compared to optimized medical therapy, LVADs increase survival in low-risk patients by 0.61 life years, real life years, and it increased the quality quality adjusted life years by 1.74 years only, at the expense of $364,000 extra dollars, which is double the amount what we should be spending. The ICER per quality for the high-risk patients, for the low-risk patients, was $209,000. For the higher-risk patients, it made a little bit more sense to put an LVAD for them. It increased the survival by 2.84 life years and 2.87 quality-adjusted life years, with an additional cost of course, $475,500. And the ICER per quality for LVADs for high-risk patients was 171,000 patients per year. Readmissions post-LVAD were much more costlier because of sicker patients and need more tests for the LVAD patients. Outpatient care was the same. There was no big difference between outpatient care between LVAD patients and heart failure patients. In the US, less than 1% of advanced heart failure patients receive a transplant. This is really interesting. They have 250,000 stage D heart failure patients. Only around 2,500 patients received a heart transplant. If we plan to insert a destination therapy LVAD for the rest of the patients, it would cost around $36 billion per year, which equates to around 6% of the entire Medicare budget. That's in the United States. Now, in Saudi Arabia, we have around, we estimate around 20,000 patients with advanced heart failure in stage D, ambulatory patients, and only 35 were transplanted last year, as Dr. Jihad showed in his presentation, because the King Faisal is the only center now performing transplant, which is 0.175% of that population. If we hypothetically calculate the average cost of an LVAD in Saudi Arabia at 60% of its cost in the States, then that would calculate to, we don't have, so we're extrapolating data, that would be 102,600 ICER per quality for the higher risk patients. If we think that around 10,000 patients would be at high risk, would be high risk advanced heart failure eligible for heart transplant, but with no donors available, eligible for eligible for destination therapy LVADs, that would cost us around $1 billion, which is 3.75 billion Saudi riyals, doubling what we are spending on heart failure yearly. I think I just gave you the numbers, and the conclusion is left for discussion. Is it cost effective? Does it make sense? And how would that, how would we convince the people who are administering and the policymakers to provide more budgets if we are thinking of destination therapy LVAD programs? Thank you.